Good morning, everybody. I would like to welcome all of you, and at the same time, we have our guest of honor, Professor Wai-Ching Lam. He is a head and medical director of the ophthalmology department, Vancouver General Hospitals and University British of Columbia Hospital, and clinical professor of the Department of Ophthalmology and Visual Science, University of British Columbia, Vancouver, Canada. Professor Lam is a vitreoretinal surgeon with clinical interest in adult and pediatric retinal diseases. He has published over 122 peer-reviewed articles. He has also authored 7 book chapters for his clinical and scientific work. He received the Achievement Award of the American Academy of Ophthalmology and the Asian Pacific Academy of Ophthalmology, the Fellow of the American Society of Retinal Specialists. Professor Lam, welcome you here in Saudi Arabia, in Riyadh, in Vitreoretinal Division, and really looking for you to have a very, attractive week with you this week. His lecture today for tips of vitrectomy techniques. So welcome on stage, and really we are enjoying to have you with us.
So thank you very much for the kind introductions, and it's always nice to visit this part of Middle East. And I think the last time I was in Saudi Arabia was also in Riyadh. It was the Saudi Retina meeting a few years back, and so I was asked to give a few lectures. So for today, I was preparing something thought maybe helpful, because I understand that this is more for the residents and the fellows, more of some surgical tips that I find it sometimes helpful in the surgery. So one thing that you may, just in case, you may find some of the information very simple, and you may find that you already know some of this stuff, but let's see if you find it useful when you actually, for those people who do surgery, you may find that practical in what they do. So, that makes sense. Yeah, great. So we're going to touch on doing sclerotomy. That seems to be very straightforward, but I just want to take a bit of time on it, and how to optimize viewing, and ways to remove intraocular silicone oil, and sometimes the problem with subretinal PFCL, peripheral carbon fluid, and then the technique to remove Denseron, the heavy silicone oil. Now, in terms of placement of the sclerotomy, I think we all quite familiar with the setup. Like, this is just a schematic. The nose, this is the right eye, and the sclerotomy is set at 2 o'clock, 10 o'clock, and 8 o'clock in terms of the reference point that the surgeon looking down to the patients. And we kind of decided, in order to avoid damage to the lens, for patients who are pseudophakic, we are 3 millimeters from the limbus. Patients who are phakic, we want to avoid the lens, so we go back millimeters. Now, looking at this picture, anybody want to comment on this picture? That is anything unusual in terms of the picture itself? Anyone? Very good. I think somebody kind of gestured the constructions of this sclerotomy, and so the sclerotomy, the way it was drawn is placed kind of on the almost like a circumferential fashions. So I'm just going to show you at this point. Now, anyone know what this tab does in the different trocar? if you assuming, I know that Alcon has a kind of major presence in most of the surgical instruments. So this is a Alcon Constellations trocar insertions. And there's a tab there. There's a white tab. Anybody understand what that does? Yeah, so it's mentioned, very good, and so it is. So it indicates the leading edges of the blade and the cannula. In addition, it actually has a little kind of groove that it fits in that will prevent the cannula from falling off and also prevent the rotations of this blade during the insertions. Now, when we insert, the intention is to insert this in this radial fashions, creating more or less like a scroll tunnel, so that the incisions is self-seal. And if you can see, on the other hand, if you rotate the blade in these fashions, in a circumferential way, then it does not create a self-sealing incisions because it doesn't have that lift of the scura that helps to make the wound self-sealing. And what's interesting is that if you look at the BNL trocar, it is a cylindrical blade with kind of half of that shaved off. So for that, you can actually see how the blade can be inserted in creating this kind of self-sealing wound. And so when I showed you the picture before, it was oriented in these circumferential fashions, and so that wound will not be self-sealed, simply because it's radial. So it's important to actually look at this tab when you insert and just not insert at random. And so that will help too. So another note that when you approach a scura and to do the sclerotomy, and there are obviously a couple of ways to insert it. One is to go straight in a vertical fashions, and the other one I just show you is going to an angle. I've also seen people try to do it so-called two steps. You can go an angle and a turn and go in. And in reality, you're actually creating an angle incisions, and the turn is only to bring the trocar in the vertical position so that you can insert it properly. Because does people know how thick the scura is at the point where you need to put in the sclerotomy? Any guess? Do you want to try again? You've been so good.
I would say it's around less than a millimeter.
Yeah, so it's less than a millimeter. So you can imagine if the scroll thickness is less than a millimeter, and you couldn't really create a two-step wound, because the blade itself, the edges of the blade, is already kind of more than a millimeter to insert. So you are in fact doing an angulated incisions and not a two-step incisions. And of course, if you go vertically, you may have to close the wound. So this is just a reminder how thick the scura is. And the thinness of the area of the scura is underneath the muscle. It's important to know that though, when we do sclerobuccal surgery, we put muscle hook underneath the muscles. And if you are not careful, that is the weakest point of the whole scura and the eye wall. And that's when you can perforate. So knowing that that is the weakest area keeps you be alert to the potential risk of perforations. And then you can see the thickest actually in the back of the eye, and then and around the equator is the thickness. So you're right, you're absolutely right. So the actual thickness of the scura is about 0.8 millimeters, so it's less than a millimeter in the area where we insert. And there's also some special considerations for children. And I'm interested in both adult and pediatric VR surgery. And I like this picture simply because baby or children are not small adults. They have their own unique considerations. And what is most unique is that the most rapid growth of the eyeball is during the first 2 years. You gain about 3 millimeters almost during the first two years. And then after that, it's only about like 0.1 millimeter growth per year up until around aged 4 or 5. Is that by then you almost reached the adult length. So it's quite important to realize that they have a different kind of size of the growth at the early 2 years. When you look at the literature where people insert their needle for injections of Avastin or anti-VEGF, and so you can see that there is quite a big variations for the insertions, from 0.5 millimeter to 2 millimeters from the limbus. How can that possibly be? You think about it, right? And so there is a quite inconsistent or no consensus. Perhaps when I was looking at the publications, then I start asking people, why would be such a big variations? And then I realized different people writing the different article has a different interest. So from a retina person, I want to protect the retina, right? So I do not want to enter into the retina at all. So those people using a shorter distance are usually retina surgeon. And the people who go posterior are the pediatric ophthalmologists who they were scared of, not the retina, the lens. I have to say, I don't know, I'm sorry that I have such a bias. I don't care about the lens. I'm a retina surgeon. I protect the retina. The lens, I can take it out anytime. If the retina is not protected, it's not healthy, the lens, for me, is just a window to get to see the focus, right? So I think that's the reason why you have the differences between them. But what is the safe distance, though, if you think about it? So a lot of people might know about this table that's been published, and it is from the Lam group. I just want to take a bit of time to explain how they come up with this incisions recommendation, the distance. So first of all, they wanted to look at, because the data actually come from a cadaver eye study that was done by Ayalo way back. So they look at the minimal cerebral body distance, which is actually done as a cross-sections of the eyeball from the locations of the ora serrata to the beginning of the pars pliccata. That's where this cerebral body distance is. So they look at the different age group from 0 to 6 to adult. You can see there's a variation between 2.6 to 4 millimeter. But when you do surgery, you don't have this X-ray reel to look inside to the eye to look at the total cerebral body distance, right? So you're looking on the outside. So this is the surgical limbus. The surgical limbus actually is the total distance that you can see. But that's not the distance that you have on the cerebral body. You have this 0.35 millimeter kind of additions for the surgical limbus. So that means the actual total distance is the addition of this sum. And the midway through it is where it's safe to enter. And that's how they come up with that number. So you can see for between 0 to 6 months, 1.5 millimeters, 6 to 12 months, 2 millimeters, and so on. So that's great. But if you look at the article, and people, I just want to bring to your attention, there are two things that has limitation with these recommendations. One, over half of these eyes in the study were older than 6 years old. So the number are not really for the newborns. The numbers are more related to the older kid. Remember I told you, by 4 years of age, they're already closer to adult, right? So, and secondly, they are all from cadaver eye measurements. And so you understand that there's some postpartum changes. And so I think when we deal with newborn, there are, besides the newborn, we also have the preemie. What's preemie? Preemie means they haven't been born, supposed to be born yet. They are less than 0 of age. So we don't have those numbers for less than 0 of age. What about PFV, persistent fetal vasculature? They often have microphthalmic eye, smaller than average eye. And we didn't have that in that table. And what about those with anterior segment dysgenesis, that the anterior segment anatomy may be a little bit distorted? So how do you manage those patients? Can you use that Lamley's recommended numbers to do the surgery to enter the eye? This paper was published in BJO by the C.K. Patel, and C.K. Patel is a consultant from Oxford. We have the fortune of working with him as a fellow in Toronto, so he was trained in Toronto with us. And so he showed this scleral transillumination technique to kind of estimate the locations of the pars plana. So they look at preemies. So you can see the 3 trials here, 39 weeks, 40 weeks, and 39 weeks. And so what they saw is that if they do a scleral transilluminations with a very bright light, the light that we use is the endo illuminator from the vitrectomy machine, so that's very bright. So this bright band that you see on the scleral transillumination actually represent the anatomical locations of the limbus. And then the dark band is actually the ciliary body, the entire ciliary body. So the midway of it will be somewhat safe to do. So what's the distance? We can see a caliper was put in here, which is set at 5 millimeters. So this marking here, you can see that is quite, probably about a couple of millimeters at most, right? So, so that's what he has kind of noted during the kind of in his kind of observational experiences. But then I talked to him and say, well, you know, that's good, but how do you know for sure that's the case? So we decided together using the UBM to kind of confirm if what he thinks is the locations, that is the midpoint of the pars plana, is actually the case. UBM should be the gold standard. You have a live view of the anatomy of the ciliary body and the pars plana, and you don't have to worry about the like post-mortem changes on the eye. So, but in order to know the locations, we use the Sinskey hook to mark it so that we can see this kind of artifact, then we know the locations. So I'm not going to take you through that, but we've done a whole bunch of children's, and we published the data, and for those people who are interested, you can read that up, and it will give you some kind of comparison between the UBM measurements and the scleral transilluminations. So I just want to bring your attention. This is the Lamley's numbers that was recommended. And so this is the scleral transillumination number, and this is the UBM numbers. So you can see the scleral transilluminations and the UBM are pretty close, 2.5, 3, 3, 3. So, and you can look at the Lamley's number. It's actually a little bit more conservative. If you think about it, it probably makes sense for several reasons. One is that the post-mortem cadaver eye, the eye may be a little smaller. So if you use, and if you have been using the Lamley's recommendation, and that's quite safe. And that's also the reason why that big range of number hasn't caused a lot of problems to the retina, because the number itself is pretty generous than we think. For the prenatal, we probably need some kind of difference in the adaptation. I think the worry for the pediatric ophthalmologist is reasonable. You don't want to injure the lens of the baby because they are, on average, thicker than the adult. So you can see here that the schematic showing this is what the adult lens relationship to the eyeball, and this is children's lens in relationship to the eyeball. And so the reason for showing this is that if you use the normal approach, that you aim to the optic nerve, you have a good chance that you might hit the lens. So when you do the babies, then you need to redirect your lens, redirect the needle away from the lens in order to avoid any trauma to the lens. So the insertion technique will be different, and you can see it should be parallel. But remember how thin the scleral wall is for adult? Less than 0.5 millimeters, right? The baby even thinner than that. So you never needed to insert the needle all the way in, because if you do that, you will be very lucky to reach to the other side of the eye and causing more damage than you gain from the benefits. So all you need to do is put in probably just a quarter of the needle or a third of the needle. That will be quite safe to do so. Of course, I think in here you already have this specialized needle that's very short, and that was intended to make it safer to insert. And so let me just move to the next one. Now, still talking about inserting now, not the needle, but the trocar. And I already told you about the angulations and the straight entry. Since the sclera in the baby is so thin, there's no point of doing the angulated approach anymore, because you're not going to get self-sealing wound from the thin sclera that you have. So, so therefore, you should, you probably need to suture the sclerotomy for all your cases, and you may as well do the vertical approach that gives you the cleanest and the easy approach, and for the ease of the instrumentations too. So, so I think that will be kind of the most, make most sense. And other things that need to be taking more precautions is that baby and infant have a lower kind of systolic pressure than adult. And so when you do scleral depressions during the examinations, whether you will be doing surgery or doing in the nursery, you just need to remember that, because don't leave the scleral indenter there for too long. And when you look at something, you want to take a look in details, so you stay there. And so that maneuver can potentially close the central retinal artery. So always remind the fellow, you're here to examine, do it quickly. You're not here to enjoy the view. So move on as quickly as you need it. And because the longer you stay in one spot with the scleral indenter, the more likely you would need, more likely you may cause some perfusional problems. Okay. Any questions up to this point? Right. I got thumbs up. Thank you. Now, like everything else, and visualization is the key. And I always said to the trainee, if you can't see, you can't do. And yes?
Thank you. Experience cases who does not have pars plana, because some nobler cases, they don't have pars plana.
Right. So I already offer you an options. So in those cases that has this abnormal anterior segment, I think it is good to use this scleral transillumination technique. So take if you are in the OR, use the endo-illuminator from the machines and place it against the eyeball, and you will see those two, one light band, one dark band. and that will give you the relative kind of safe location in the midpoint of that dark band. And that may not be a very normal plaster. There may be a very kind of changed, aberrated or altered plaster, but that will be the safest place to enter. Yeah. So those numbers that you read on the table will have no particular use because they change of the anatomy. Okay, so this some of you may find relatively simple, but I thought it would be useful to do. So things that can go into anterior chamber: air, blood, fibrin, PFC bubbles, oil, all that can get into an anterior chamber, and it's a nuisance for the surgeon to try to kind of do the surgery. And so air bubble in AC. Yeah, very good. So you just test to see people paying attention or have you had coffee this morning. So I cheated you. That's not bubbles in the air bubble in the AC because those bubbles are sitting on the bottom of the anterior chamber, so they cannot be air because air floats. So thank you for pointing that out. So when does it happen? It happens maybe after air fluid exchange. It can happen after pneumatic retinopexy. So why did it happen? It happened probably because there may be some zonular abnormalities, so the gas can find its way to the anterior chamber. And patients who are pseudophakic, who has a very big posterior capsulotomy, may also have access to it. Also, when you have anterior chamber hypotony, when there's an imbalance between the pressure from the back of the eye to the front and a leaking wound, whatever the reason, then the air bubble can go into the front. So this is what I do, and there's many ways to do this, but this is one of the ways. So there's air bubble in the AC, and I have a needle with balanced salt solutions. And what I first do is inject balanced salt solutions into the eye, so that firms up the eye, and then I will aspirate the air bubble with the needle. The reason for that is that you need to pressurize the anterior chamber, because if not, you take the air bubble out, the gas or the air bubble from behind will try to migrate forward. Then I will repeat this several times until the air bubble is removed. So again, balanced salt solutions is injected into the eye, pressurize the anterior chamber, and then you can aspirate back to draw the air bubble. But one small tip is that when you aspirate it at this point and the pressure starts to get low, you pull the needle out and don't stay in there and try to inject the balanced salt back to the eye, because you see here in your needle and your chamber, there's air before the fluid. So you need to take the needle out, express out the air, and leave it the syringe is filled with balanced salt solutions, and inject into the eye again, and repeat that to get rid of the last bubble. So one more time, because if you do a push and pull steps, then you basically push back the air bubble into the eye, which is kind of waste of time, because you just aspirate out the air bubble and you put it right back on. Okay, so that I found the technique to be quite helpful to do that. And a 3cc syringe with balanced salt solutions is easy to handle with your one hand. And anything's too small, 1cc, I find it doesn't have enough kind of aspiration. Too big is also hard to handle. So blood in the anterior chamber is also a problem, and it can be from the bleeding from the new vessels in the iris. It can be from the hemorrhages from the back of the eye that migrate to the front, especially in those pseudophakic patients, and or trauma during surgery that can cause it. The procedure is similar to what I have done with the air bubble. So we do this, you can do this actually in the outpatient clinic in the sitting positions. you stick the needle in. But this time, because you want to get rid of the blood, I use air instead of balance salt solutions. And so first thing, you stick it in, you inject air, you pressurize the globe, and then you pull the needle back, and then you draw the blood out. In fact, when the eye starts to pressurize, you pull the needle out, the pressure inside the eye will push some of the residual blood out through the 6 o'clock paracentesis site, and that will allow you to have the eye full, the anterior chamber full of air and no more blood. And at this point, you can either do two things. You can just leave it like that, or you can take what we did with the air in the anterior chamber using the balance salt solution and replaced and take out the air bubble and put in balance salt solutions. Now you have done a complete fluid, air, and then air fluid exchanged in the office without having to take the patient to the operating room. And it may be useful because if you have a patient that you're concerned and the hyphema is not clearing, and the question you have is, do I need to take this patient back to the operating room? So this procedure can give you some opportunity to do this without taking the patient back to the operating room. Okay, now this is the real thing. So this is PFCL bubbles in the anterior chamber. So what are the causes for that? Usually you don't see that in the anterior chamber, and that could be because during the removal of the PFCL bubble in the posterior segment, you didn't completely clean that. And that can happen because, there may be corneal edema, there was other things that makes you not able to see because PFCL is transparent, and you may miss that. And people now also have intentionally put PFCL inside the eye for a short period of time, for 5-7 days to kind of tampen out the giant tear, and especially those that was difficult to operate. And if you do that, when they face down, the PFCL bubble from the back can move to the front. And but the problem though, that's not a good thing to have because PFCL can cause inflammations. And in addition, because it's heavier than fluid, right? Even though we are retinal surgeons, we still need to take care of the eye and respect our cornea colleagues because that will put pressures on the endothelial cells and will damage the endothelial cells, and it's not good to the eye in the long run. So we should find a way to remove them and not leaving it into the eye for too long. So the technique is like taking out the blood in the hyphema. So I use air, and I think using air is easier and better than the using fluid or balance salt solutions. So the procedure, you inject air inside the anterior chamber, pressurize it, you withdraw the needle and aspirate. And what happens is that often you have more than one tiny little bubbles because they can break down into multiple bubbles. Just for the trainee, in silicone oil, you get emulsifications. You get tiny little oil bubbles. And what do you call this in PFCL? This is not emulsifications, I tell you that. What's the term to describe this? It's called dispersions. You break down the bubble because of pressure. And we see that more often these days in vitrectomy, and we see them less often in the older days. Anybody has any idea why that's the case? Yes. Yeah, it's when we now moving to the small gauge vitrectomy, you have a higher jet flow, and that disturbed the PFCL bubbles, and that causes dispersions, and that causes multiple bubbles. In the old days, when probably many of you haven't, except the senior doctors, you don't do 20 gauge. In 20 gauge, the flow less high, not as high as the 27 to 25 gauge flow, and there's less dispersions. And that's why we see, I never saw any PFCL bubbles, subretinal bubbles, when the 20 gauge vitrectomy era is now that I can see them from time to time. Anyway, so that's one technique to remove the PFCL bubble. And the last little bit of the bubble and you can just using the needle to kind of open up the paracentesis site and put some more air, and they will force them out. You can't use the needle to draw the last little bits of the PFCO bubble, simply because the needle hub and the bubbles may not able to meet properly. And then if you don't like to have the air bubble inside the anterior chamber, repeat the first step, put balance of solutions and get the air bubble out. Then you have a fluid-filled anterior chamber, and it will look as good as new. Any questions so far? So sometimes you have this pupillary membrane in the anterior chamber after surgery, or for me, when we operated in young patients, but for patients with uveitis, this is sometimes happen because of the very kind of exuberant reactions, and it is a border for two reasons. One is it limit our ability to see in the back of the eye, but that fibrin membrane, if we leave it for too long, it can cause secondary problem, become structural, like they actually form a fibrous membrane. And that is not a good thing, because it can cause things of this nature, like distorted the pupil, and it will actually block your view. And before it reaches to these stages, there are ways to manage it. Just put in the intracameral tissue plasmin activator, and you just inject into the anterior chamber, wait 10-15 minutes, and it will essentially melt the fibrin membrane. But it has to be at the fibrin stage. Once it becomes a membrane, it won't work, because the fibrous tissue is not going to melt. It only melt the fibrin with the TPA. So this is emulsification. So this is when you have oil, so in the sitting positions or in a lying down positions. And so in the sitting position, we call it reverse hypopian. In a kind of supine position, they are often in the front. You see, when I try to get this bubble out, so I do a kind of exaggerated tunnel the corneal incisions, so that I have a self-sealing wound, and then so you can then just irrigate out the balance of solutions through that corneal wound, and that will I try to okay, it's there. And that way you can minimize the problem, because if you have a wound that too generous in size, then the manipulations that you do will actually create more bubble coming out from behind. So if you have this nice kind of clear corneal incision in a kind of tunneled fashions, then you can irrigate out the oil from the anterior chamber, and without having to worry about more of this oil can come from the back of the eye. So the key is to make sure that the pressure in the anterior chamber is maintained. People have done using viscoelastic and to do so, and that's fine, but you have to deal with the pressure that builds up afterwards, and that can be a problem also. Band keratopathy is another problem that sometimes run into as a retina surgeon because of the use of silicone oil and the buildup of the calcium. And from chronic uveitis is also an issue, and patient with chronic retinal detachment. So I learned it from my anterior segment surgeons. So you scraped off the epithelium, and then you put sodium EDTA 1.5%. You can either soak it in a spear and place it over it, or you can put a little cap. For us in retina, we have this flat lens that has a rubber ring. You can put it over the area, and then afterwards you can just put the EDTA over it, and then you can, after 10 minutes or so, you can just scrape it off and irrigate off. You just want to make sure that you get rid of the EDTA. Another tip that can help to prevent other injury to the conjunctiva or the limbal areas, I usually put some ointment over the conjunctiva and the limbus so that the EDTA would not stay on the surface and damage the other areas. So I'm just going to move to the very end. So at the end, you can see that band keratopathy is removed. Then you can proceed with your planned surgery and able to see to the back. And here is another kind of annoying experience that people may have, is the fogging of the posterior part of the lens. And anybody know the reason sometimes this happened? Yeah, so it only happened if the patient have a posterior capsulotomy. And if you don't have a posterior capsulotomy, then this doesn't happen. So if the capsule is clear or just a minimally opacified, leave it alone, because if you do the air fluid exchange, this will happen. And also there's also due to the temperature differences in the body and the outside. So the fluid will create a little bit of a kind of like humidity that settle onto the surface as you start creating a separate air and fluid interface. And there's different ways to deal with this. And people have putting viscoelastic over the area so that you can have a coating of the posterior surface of the lens, and that will allow you to have no more kind of this fogging. And you can also just swipe it with the instrument, and I'll just, yeah, so let me just see. Oh, sorry, I think I may have went too quick there. I think it's in here. Yeah, so you can inject viscoelastic to the back, and that will create a nice clear interface, and then you can carry on doing the surgery without the, so the view is a lot better, and you can then do your surgery without the difficulties. And so that's next one here. So I don't know whether any one of you have this experience. Anyone know what, if you read the small print, you may see it, but so you know what's happening here? Yeah, you get silicone oil stuck to the IOL. And that happened because of the lens, the IOL, is made from silicone also. You don't see it as often with the other types of the IOL material, but if you have silicone IOL, I think people use less of that. It's a foldable lens, and that if you do silicone oil placement in those patients for like retinal detachments, and when you take out the silicone oil, you get silicone oil stuck to the posterior surface. And so what do you do? How do you manage this? And anybody has that unfortunate experience? It's hard to get rid of it. Like, the technique that you use to get rid of the air bubble with the swiping doesn't work. You put viscoelastic, doesn't work because it's stuck there. And so somebody was quite clever, and they found that the oil is hydrophobic, but it can dissolve in PFCL. In fact, for people who doesn't know, the Densaron, the heavy silicone oil, is a mixture of silicone oil and perfluorocarbon fluid. So if you mix perfluorocarbon fluid with silicone oil, it becomes a single solution. You can dissolve them into a single solution. So for that reason, it's an expensive way, but you can use perfluorocarbon fluid. You can spray it behind the IOL, you can wash it off. The oil will wash off with the perforamin fluid. And so that's one way. And other people has suggest using a different technique. I found that the technique using the perforamin fluid is probably the most efficient way. And the other one that people use in Sinskey hook and using lens hook to get rid of it sometimes work, that doesn't always work well. And so I'm going to talk about a very common procedure, like creating a posterior vitreous detachment. I just wanted to do this simply because there might be just a bit of kind of technique that people do. So using triamcinolone helps to identify the vitreous, and it allows you to see if it's still attached to the back of the eye. But I wanted to show you. So when you engage the vitreous with the cutter, you can lift up the vitreous. But I just wanted to show you something that is worth remembering, is that when you, it looks good when you do that, but the technique that you actually create in posterior vitreous detachment is that, if you look at this diagram, when the vitreous get aspirated into the port, it blocks that port. Like the vitreous is not going to migrate up all the way on the aspiration mode. It was stuck right there. And so if you put the cutter and try to create a posterior vitreous detachment from just the aspiration, it doesn't quite work. In fact, the idea is that you engaged the vitreous, and then you actually mechanically lift the vitreous from the attachment. It is the mechanical lifting that you create, not the aspiration. The aspiration is to engage the vitreous, because I've seen some of the trainee, they put the cutter right next to the optic nerve and then just kind of push down the foot pedal and kind of jiggle around and try to create the posterior vitreous detachment. That won't work. In fact, actually that's dangerous, because if you didn't engage the vitreous completely, you suck too much water inside the balance into the eye get hypotenuse, your cutter will touch the nerve or the retina, and that can cause bleeding or damage. So again, the idea is to engage the vitreous, let it occlude the port in the cutter, and then you mechanically pull, and when you had it fully engaged. And for that reason, you can see you have to look at the shape of the vitreous. You can approach the vitreous from inside out or from outside in. But whatever you do, you just have to make sure that you have the vitreous engaged to the port. So you can see, if you do it this way, it may be safe, but it takes more vacuum to bring this vitreous in from these directions instead of coming it from the side. So you need to look at the orientations of the vitreous attachment and then try to create the separations from that point of view. That seems to be a very simple procedure, but it can be more challenging. And for the last probably 10 minutes, we're going to talk about silicone oil removal or injections. And it's not complicated, it's relatively simple. But to get 100% or full fill sometimes is tricky. So, so I found that I usually do a direct visualization with the biome, and then you fill the, just 1 second, I want to get this video started. So you fill the eye, this is a biome view under air fluid exchanged, and so you fill the oil all the way up to the edges, and then the last little bit of the oil, I put in either the little chimney, the vent, and the reason for that is this allows the air to escape and also allow me to control the pressure. And if you don't use the chimney, some people use a 30 gauge needle to tap the air bubble at the end and then fill it. And this way you'll be able to have like 90 to 100% fill, because often, when you still have the air infusion, you may not able to fill the pressure or fill the eye completely with the silicone oil. And then for patient who's aphakic, it's probably useful to remember to do an inferior PI to avoid any pupillary block at the end. So that's the insertions. Yesterday, we have a case where we take out the silicone oil and with the fellow doing the case. And I think that was done beautifully. So you can either extract it through this device, which kind of grabs the entire cannula that aspirated. But I just wanted to remind, especially in this region of the world, about the oil. And you know, the oil floats on the surface of the retina. They are not sunk or mixed with the fluid, and they float on the surface of the fluid. I meant, and so when you take out the fluid, you want to take out the oil first, not the fluid, because if you don't take out the oil first, at the end you get a chunk of oil at the optic nerve, and it's hard to remove that with a 25 gauge cannula. Remember, when you were using the oil removal devices, you're aspirating at about 650 kind of millimeter mercury to suck the oil out. If you're leaving the oil at the end, it's no good. So, so what I meant is that if you look at the fluid and the surface where the oil is, what you're doing properly is that you kind of touch the fluid interface. You can see the change there. Then you aspirate fully. And as soon as the fluid level drops, you stopped. Then you reach out again to the fluid interface. So this way, you're basically skimming off the oil on the surface. So you always have to think, where's the oil? So if you put your cannula inside the fluid, what you're doing then is you're actually aspirating only the fluid. So you see, when I touch the interface, there's fluid. And so I'm aspirating the surface of the fluid, which is the oil float. Again, I've stopped, I'll touch the interface, and that's where the oil is. Then I aspirate very kind of full aspiration, and then the water would drop. Then I've stopped. Because I don't want to aspirate air, because if you aspirate air, the eye gets soft, and the machine will tell you you are bringing the eye too soft, hypotony sets in. So you kind of repeating, touching the interface, touching the interface with the cannula and the flow of your aspirations, and then stopped. If you do that, then you will be successful in getting rid of the oil without leaving the oil at the end. Because at the end, if you are not successful, then you get a dropped or a chunk of oil at the end, and it's very hard to remove it in a 25 gauge cannula. And 5 more minutes. I just remember I just told you about the Denseron. So Denseron actually, some people get mixed up with the heavy like silicone oil versus the high density silicone oil. Heavy silicone oil means they actually sink, it doesn't float. High density silicone oil still float. It's 5,000 centistokes of oil. The benefit of that is that you have less emulsifications with the higher density, but not because they sink. So when people say about heavy silicone oil, it's because they have a mixture of the silicone oil and the perfluorocarbon fluid. And so this is one of the older video that I used a 20 gauge, and you can use the kind of the angio, like the IV tubings. They are, I'm not sure they make from polyvinyl or whatever it is, but the silicone oil and the perfluorocarbon fluid mixture will loves to stick to it. So you can see, you can bring it down to the smaller volume, and then it will stuck to the cannula, and you can see it there in a minute, and then you can use your light pipe to migrate. See, you're lifting, getting it out, and you can stay there, and you can just using the light pipe to guide it to the tip, and then you can aspirate it will just stay to that area. So that's one technique that I was using before to get rid of the stuff. So, and then quite often you get this membrane that forms underneath the interface because the perforating fluid is pro-inflammatory, so you often get the inflammatory membrane. So you need to remove that also at the end of surgery. But another simpler technique is that you can just put in the cannula through the to your port, and you keep aspirating, and it will stuck to your port. And so you don't need to use that. I didn't realize that when I first using that technique, and then realized, oh, even simpler that you will stay into that area. And so this is another quick videos from a colleague of mine, Amin Karani from Calgary, and showing the various kind of much the same. You can just, they use the Denseron a lot. I don't use it very much. So you can see it just stuck to your infusion to your aspiration cannula, and then you can use everything with that. I think I will stop because I can go on to talk about the different techniques of removing subretinal perforating fluid, but I also know that the time is 8:26, and I know that many of you have other responsibility at 8:30, so I'll leave 4 minutes for any questions that you may have. And okay.
Yeah, thank you, Professor Lam. This was great to have this with all these tips that helpful in surgical, dealing with vitreoretinal surgeries. So I would like to open if there is any questions. Feel freely that to ask, please. Anyway, Professor Lam with us for all of this week. So at any time you can sit with him, and if you have any point to be discussed, or even though you have need to ask him about a lot of other maneuver, I'm sure that Dr. Lam is usually is positive in that situations.
Thank you very much.
Thank you very much, and I think this is the time to leave for the surgery.
Yeah.
Thank you very much.
Thank you.